Hi, everybody. Welcome to Perfusion Musings, the podcast held by Envello Medical. Dan and I are joined today by Dr. Jacob Møller.
Dr. Møller is the professor of medicine at Odense University Hospital and University of Southern Denmark, and a cardiac intensivist at CICU at Copenhagen University Hospital. Dr. Møller, our audience will recognize you as the PI and lead author on dangerous shock, but also you have been publishing and researching in this space for a long time. So we're pleased to have you on the podcast today.
Pleasure to be here.
Dr. Møller, a lot of your research talks about patients when they're in transition. And some of the most really interesting aspects of the underlying physiology to us and what really shows the need for advanced monitoring is how dynamic those patients are. Can you talk a little bit more about how those patients are dynamic and how you assess them to be adequately managed?
So that's a great question and a really difficult topic. Perfusion is really all the time changing, and the heart is all the time changing its output to meet your metabolic demand. And if the heart cannot do that, everything goes wrong. So in the situation when you're resting and the heart is not able to meet the metabolic demand of the body, then the catastrophe will be there. And the patient will go into shock and the spiral starts and everything goes bad. So I'm beginning to learn that we have to catch the patient before that happens. And that's not so easy. And especially when we talk about cardiac output, we always measure blood pressure. And that's really not the answer, because the blood pressure is kind of maintained for a long time, even though flow will start to decrease. So just looking at a blood pressure will not be the answer. And these patients in the transition, they can be there with the normal blood pressure and the heart rate is maybe a little bit increased, and then they crash, and then it's too late. So if we're able to step in before this happens and detect that perfusion starts to go down, maybe we can avoid the catastrophe of shock. So and this is really something that I learned out of our animal labs, where we do studies on where we do microembolization to induce shock in large animals. And what we see is that it's not until cardiac output is decreased by 25%, blood pressure will start to decrease. And this is really a key learning for me. So that's why I think looking at perfusion is so important.
Interesting. I actually have a follow-up question to that real fast. Sorry. I'm following the SCAI stages, and I understand that we can stage patients that SCAI A looks generally like this, B looks like this, and those patients, once they're in those SCAI stages, are sort of defined. Do patients transition similarly between those stages, or does everybody transition differently also?
I think people transition, it's very individual. I don't think you can, I think SCAI stages are so good for communication. So if I say I have a SCAI stage C patient, everybody kind of have a picture of this. But when you start to use it on the individual patient, it gets really a lot more difficult. So these very specific cutoffs. So if your lactate is 1.9, your SCAI B, if it's 2.0 or 2.1, it's all of a sudden SCAI C. And patients will transit in and out of this, also depending what they're doing, if they're anxious and or if they're moving a lot. So it's changing all the time, and I think it's that's where it becomes much more important looking at trajectories than cutoffs, and that's where these things really can kick in my mind. Lactate is another. I love lactate. I mean, it's such a strong predictor, but it's it's only when it's up, it's too late. When lactate is 2.5, then it's too late. You are in the circle already. You might be able to reverse it, but you're on your way to deteriorating. So we need, maybe if we had a lactate monitor, I don't know, that would be cool as well to see trajectories of that. But it's just that we have to look at something continuous, because these changes are happening all the time.
Yeah, you made a similar point when I saw you at THT earlier this year, and you talked about blood pressure not being a great indicator. Lactate mentioned, even point of care ultrasound, because they're not continuous. So what kind of perfusion are we talking about? Like, there's measuring perfusion in many places on the body, and where are these gaps? Where are the gaps to be able to measure perfusion today?
So what we of course need to assess is that the vital organs are perfused adequately, and that's super tough. And sometimes we have I see patients that are really in shock. They're ice cold on arms and legs, and their lactate is 3, and then I take a central venous oxygenation, and it's 60, because all the blood supply to the arms and legs are shut off, because arms and legs are not important when you're going into shock. Your brain and your kidneys are important. So I think you have to measure it somewhere central on the body. So it will never work on a finger or a hand or a leg, because they're simply not important when you become very ill. So it has to be more central measurement to catch these things, would be my guess. Maybe both a center peripherally and centrally to see different signs there.
Yeah, actually, that's a really sort of insightful, interesting way to think about it. Do we have an individual anatomical location that gives a threshold of good, bad, and ugly? And do we look at deltas and say, all right, well, the chest or the sternum is a little low, but the leg is really low, or
Yeah.
the leg's actually okay, and the chest isn't great, but the patient overall is kind of equivalently compensated. Perfusion trends are really interesting, especially in that transition period that we talked about. Do you find that the trends reverse? How long do you feel for the reverse to go before you feel good about the patient? How much data do you need to amalgamate before you can begin feeling that things are going in the right direction?
So again, I'm looking at lactate for this, and when I see lactate going down, I start to relax. So a drop in lactate, and sometimes I look at it after 1 hour or so, but to see a lactate going down, then I start relaxing more. A lactate that is not decreasing, or if it's increasing, I know trouble is coming. So again, it's the trajectory of that, and I look a lot more on that than on pressures or CPO. I think it's the metabolic consequence you see there, and that's the key to the treatment and to the patient.
You mentioned a couple of times when you see it changing, when you see things changing, you make a clinical decision. But who else needs to know? Like, if we're moving, technologies advancing, we're going to be able to monitor more things. How are these decisions made at the bedside, and who really needs to know this information if it can change this fast?
I think the real key to these technologies is the patient that is not monitored in the ICU. We have a lot of monitoring in the ICU, so they would be nice to have there, but maybe not as much need to have, because we have so many other things going on there. But in the kind of intermediate ward, I think there's a huge opportunity these patients that are kind of a little bit grayish, but not really sick enough to go into an ICU. So a Sky class A, B, those patients, monitoring them for maybe 12 hours, 24 hours with such a device would be able to pick up maybe some signals of deterioration. And I don't think the devices we have or the treatments we have right now allow us to use them prophylactically. So I think the DTU trial that just was published is a very good example of that, because it's very clear that putting an impeller into somebody not in shock has a cost of complications. So putting it into a lot of patients, such a device, where only maybe 10% will really need it, will cause a lot of harm, and the benefit that may be there will drown in that. So having some sensor to say us trouble is coming now, you have to start monitoring intensely or even treat patient. I think that would be the way forward.
Do you think this?
Obviously, it should be tested in a trial, but I think it makes sense.
Do you think the same challenges exist in different types of care centers? Here in the United States, certainly we have challenges with patients who show up at rural hospitals who are understaffed or under-equipped to manage or identify these patients. Is that, in your experience, in Europe, the same way?
I think in Denmark, we have a luxury of a super centralized and very structured healthcare system that is all public. So our care for primary PCI patients are centralized in 4 centers in all of the country. It's a very small country, but still it's we have 6 million people and 4 cath labs doing primary PCI, and we transfer patients with our very well-equipped EMS system to these 4 centers, either by helicopter or by ambulance. And again, there, putting something like this on a patient with a STEMI could also give you an idea that somebody's coming in where that may be in trouble. But I think for other healthcare systems where it's difficult to get an echo during the night, there may be 2 hours before a sonographer can come in. The lactate may not be readily available. Something that is very simple could also be an indicator. Listen, here's something going on. So especially in such a setup, I would think there could be a room for it.
Yeah. So digging in a little bit more to this bridging measurement to action question, whom else in the care team do you think we should make sure understands these measures that you're interested in?
I think it's the people who are taking care of the patients. So it's not only the physicians, but it's also the nursing staff that are seeing the patient that should also pick up these signs to alert the physician. So there should be a lot of levels in it. So we need to get all the staff that are really there with the patient on board on this as well.
Yeah. I want to ask a question about your clinical intuition. You're an expert in the field. You've been practicing for a long time. You've seen a lot of patients get better and a lot of patients get worse. And you have to amalgamate just a huge volume of information, some of which is just information, some of which is data. How do you go about, I know you probably don't have a conscious way of weighing all of the different metrics that you look at, but how do you go about feeling this is better-ish, this is not much better? How do you kind of think through that experience? So I'm very worried as a person who's interested in sensors that we're going to overwhelm people just with information that's not useful. So I'm really curious about the actionability of your own algorithm.
Yeah, that's a good question, and I often ask myself, it's also all these prediction models we have. Then we can predict A, B, and C, and they are there, but we don't use them. And why don't we use them? Because there's so much more, and I think it's our really our gut feeling sometimes that playing in. It's like when I call the surgeon up to look at one of the a critical ill patient in my ICU. I start blabbing there that the cardiac output is this, and the pulmonary pressure is that, and the blood pressure, and I'm giving all these drugs, and he just doesn't care about what I'm saying and think it's really boring. And he goes in and look at the patient, and then he knows whether to operate or not. So he's not using all. He has this AI going on, and I guess with my experience, I have a shred of that as well when I go in and see the patient, that I get a lot of information that I don't, that I'm not, that is just going on some way.
Right.
But again, it's getting the surgeon into the patient, or getting me or one of my better colleagues in to get us alerted. And that's because if I don't hear about the patient, how can I get the patient into my ICU? If I don't call the surgeon, how should he operate the patient? And that's where these devices come in my mind, that they alert us to say, you have to come here and look at the patient. So that's it's not going to be now you have to do this or you have to do that treatment thing, but it's more a sense that you have to come and evaluate what is going on here, and that would be.
Like you said a couple times, measuring trends. That means you have to know to go look. So you have to at least get into the room, and then you can see.
Yeah. So we move a little farther along in the patient experience. Some patients are going to get sick anyway, even if we catch them early, and we end up putting in all kinds of things, temporary mechanical support, and even more invasive and transplant. How do you think perfusion monitoring can assist in those scenarios when we have hemodynamic support on board, or maybe even weaning? How do you see this same new idea of perfusion monitoring continuously helping?
It's pretty much the same. Again, if you start weaning, you look for trends, and the more granular trends you get, the better. Again, I've been shouting for a lactate monitor or something else. Right now, I use a lot of SVO2 monitoring, lactate monitoring, look at the blood pressure when we start to wean, but none of us know what is the right weaning protocol or what is the optimal way of doing it. But again, I could obviously see for somebody with a large bore device, we already do that NIAS on the legs to catch limb ischemia, and that's another obvious use. But also, again, look at the central perfusion when you start to wean. If it starts changing, it may be a sign of trouble. But I may be wrong, but I see much more opportunity outside this scenario where we have all these catheters and other ways of monitoring the patient. I see the really big opportunity is before the patient gets into the crazy world of the ICU, and that's where, I mean, all the patients are. It's a fraction that enters the ICU.
I have maybe one last question here, and I like the way that we send you some questions in advance. As you know, I like the way this one is worded so well. I'm just going to read this one directly. In your view, where is the greater risk today? Overreacting to imperfect signals or missing early signs of inadequate perfusion? Which is a bigger risk?
I think it is a huge risk overlooking signs of hypoperfusion, but I think but I truly believe we look at the wrong things right now, and that's a danger as well. That we're just monitoring the wrong things. So I think it's a lost opportunity that we don't catch these patients earlier. So some we can't catch, some we can catch, and that is really a missed opportunity. And I think we are looking at the wrong things.
So they're both risks. We'll work on reducing both.
Yeah.
Yeah.
Well, this has been a great conversation. It's wonderful to see you as always. We'll look forward to seeing you again shortly. Appreciate your insight, everything you've done. Teach us about the anatomy and the dangers of shock, and for all of your work. We appreciate you being on today and sharing your insight.
Great being there. Thank you.